Hello, Clinic Review family. It's Dr. Sharon with Clinic Reviews. Today we're covering cardiogenic shock, which seems to be a natural progression from heart failure, which I did a couple videos ago. So let's go ahead and get started. Hello, Clinic Review family. It's Dr. Sharon with Clinic Reviews, the home of the very best NCLEX review in the entire universe, in my opinion. Mark Klimek, the GOAT himself, does the online on-demand NCLEX review. It's over 21 hours of prep to take your NCLEX. I get messages all the time from people telling me they passed their NCLEX, so that is very exciting, and you can do it too, y'all. There's everybody, if you finished a nursing program, y'all, if you finished a nursing program, you can pass your NCLEX, okay? You got to know how to take it and how to answer questions, and that's what it focuses on. What we do here on the YouTube channel is not the same as what Mark does in his online on-demand clinic review. We also have a streaming service and a monthly tutoring, small group tutoring that we do. All right, so we're talking about cardiogenic shock today. Let me just talk a little bit about it. So a couple videos ago, we did heart failure. Heart failure is always a decreased cardiac output. So decreased cardiac output is the blood that exits the heart and perfuses the tissues. So when you have decreased cardiac output, people are always fatigued. They're always short of breath or dyspneic, and they always have decreased urine output, because if you have decreased cardiac output, then you have all those signs and symptoms. So what happens is if you have decreased cardiac output for long enough, eventually your blood pressure starts to drop. And the cardiac output, so let's just say that it goes from, these are made up numbers, 100 mils a minute to 25 mils a minute, right? That's a big drop. That's a big drop. It's a 75% drop. So from 100 mils a minute to 25 mils a minute, what do you think is going to happen to blood pressure? Because blood pressure is stroke volume times heart rate times systemic vascular resistance. The resistance is the constriction and the dilation. Well, if blood pressure equals stroke volume and cardiac output goes down, cardiac output plays a big part in stroke volume. Stroke volume is actually a subcomponent of cardiac output. So cardiac output is actually stroke volume times heart rate. So you end up having a drop in blood pressure. So blood pressure equals stroke volume times heart rate times systemic vascular resistance. So if stroke volume goes down, blood pressure goes down. So that's what I'm saying. If it goes, say, from 100 mils, again, I'm making these numbers up, y'all, 100 mils a minute to 95 mils a minute, that's a decreased cardiac output, but that's not going to drop blood pressure. But if it goes from 100 mils a minute down to, say, 25 mils a minute, you're going to see a big drop in blood pressure. And what is the definition of shock is decreased cardiac output, but you have to have decreased tissue perfusion, right? It's a decrease in tissue perfusion, and you have to have adequate arterial pressure, which is what blood pressure is. Okay, you have to have adequate arterial pressure to perfuse the tissue. So if your arterial pressure or your blood pressure drops, you're not going to perfuse your tissues, you're going to go into shock. So shock is always a drop in blood pressure. I just said a lot of words. I hope that you followed that, okay? So cardiogenic shock is a result of decreased cardiac output to the point that you're not perfusing your tissues. Because there's neurogenic shock. Neurogenic shock is also a drop in blood pressure, but it's for a completely different reason. And then we have hypovolemic low volume shock. That the drop in blood pressure is from low volume. In neurogenic shock, the drop in blood pressure is from vasodilation. So there's different types of shock. They all end up in low blood pressure and poor perfusion, but the cause is different reasons. Now, how do we treat hypovolemic shock, low volume shock? Well, we give volume, y'all. That's how we treat it, right? How do we treat neurogenic shock? Well, it's a vasodilation. We need to vasoconstrict. So how do we treat cardiogenic shock? Well, it's poor cardiac output. It's not a volume problem, and it's not a vasodilation problem. It's a cardiac output problem. So how do we treat decreased cardiac output? Well, we have to give medications that improve cardiac output. They're called inotropes. Inotropy is the force of contraction. So something that's called an inotropic agent increases strength of contraction. And if it's a decreased inotropy, it decreases force of contraction. So we want to give inotropic agents. Now, there's another word that you need to know what it means. It's called vasopressors. Vasopressors will vasoconstrict. Now, that's not a great option with cardiogenic shock. If someone's in cardiogenic shock, you want to reduce the force against which the heart has to pump. Okay. And so if the arterial pressure goes up, the heart has to work harder to eject blood out into the vasculature. So you don't want to do too much vasoconstricting. But if their blood pressure is like 40 over nothing, you are going to have to do some vasoconstricting to try to get that pressure up. Otherwise, they're just going to die from poor perfusion. So a lot of times treating cardiogenic shock is a combination of an inotropic agent, increasing strength of contraction, and then giving a vasopressor, which vasoconstricts until the heart can recover and you don't have to do the vasopressor anymore. So that's not first line. Vasopressors are not first line, y'all. First line is to decrease some of the fluid, because if the heart can't handle the volume of the body, it starts to get weaker and weaker and weaker. So the volume in the left ventricle ends up backing up into the lungs, and then it backs up into the right side, and then it backs up to the jugular veins, right? And you have jugular venous distension eventually. So you have crackles in your lungs. This is all heart failure. And eventually, when cardiac output decreases enough, you have a drop in blood pressure. Okay. So the first thing to do is you want to decrease overall volume so the heart doesn't have to work as hard. Then you want to give an inotropic agent, something to increase strength of contraction. And then if you have to, you can give a vasopressor, because, I mean, you might say, well, if you give a vasopressor, it's going to make the heart work harder. It is, but if the idea may be that if we don't give it, they're going to die. So we may give it in the short term so that we can maintain perfusion of the tissues. So mean arterial pressure, MAP, mean arterial pressure is the average pressure on the arterial side to maintain perfusion. It's systolic plus diastolic divided by 3. So let's say someone has a blood pressure of 120 over 80. That would be 120 plus 80 divided by 3. That's 280. That would be like 90. Divided by 3, that would be 90. Okay. So your MAP is 90. Well, it has to be over 65. The MAP has to be over 65 to be able to say I have adequate pressure to maintain perfusion. So if your MAP is 90, that's good. If your MAP is 80, that's good. If your MAP is 70, that's good. If your MAP is 65, that's the low end of normal, but that's still okay. But if the MAP drops below 65, now we're worried that we're not going to perfuse your tissue. So if their blood pressure is 40 over nothing, obviously the MAP is close to 0. So that's very concerning, right? Okay. So remember, shock is always low blood pressure. Cardiogenic shock is when cardiac output decreases enough that MAP, mean arterial pressure, actually drops. So, and it has to drop enough for that to happen, because normally what happens if you decrease cardiac output, 25% of cardiac output goes to the kidneys, don't forget. So cardiac output drops, stroke volume drops. I'll say stroke volume drops. What's the earliest symptom of stroke volume dropping? Well, stroke volume drops, blood pressure is tempted to go down, right? So how does the body compensate for that? It can actually increase heart rate. So if stroke volume goes down, heart rate's going to go up. That's fine. That's a compensatory mechanism. The problem is when you have a weak heart, the compensatory mechanisms actually do more damage than harm than good. They do more harm than good, because as heart rate goes up, it makes the heart work even harder, and now it's getting tired even more easily. So when someone is in developing heart failure, or they have heart failure and they're starting to go into shock, the first thing is the heart rate's going to go up, which makes the heart work harder. So now you may have even decreased cardiac output or decreased stroke volume. Then you stop perfusing your kidneys. So you have decreased urine output. So now you're retaining even more fluid. They're already fluid volume overloaded. So now they're retaining even more fluid. And so all these things don't help. And so they end up going into this fluid overload shock. And we have to get the fluid off. We give an inotropic agent, which increases force of contraction. And worst case scenario, we can give a vasopressor. Okay. Let's do some questions. A nurse is assessing a client with suspected cardiogenic shock. Which of the following findings is most characteristic of cardiogenic shock? Warm, flushed skin, hypertension with a widened pulse pressure. I know that's not true because we said hypotension. Weak, thready pulse with hypotension. So if you have decreased cardiac output, you'd have a weak, thready pulse. That makes sense. And hypotension is classic shock. Bradycardia and bounding pulses. Well, bradycardia, no, because the heart is going to respond by increasing heart rate, and bounding pulses, you've got to have pretty good circulation in order to have bounding pulses. So I wouldn't say that. So I know C is correct. Is A correct? Is there warm, flush skin? That's not classic that I know of. If they have decreased cardiac output, actually, I would think the skin would be cooler. So that doesn't make a lot of sense. So I know for sure that C is correct because the hypotension, then I think decreased cardiac output is going to make those pulses, right? To palpate the pulse. You've got to have pretty good cardiac output to palpate that pulse. So if it's not good cardiac output, you're going to have a weak, thready pulse. A client arrives in the ED with acute pulmonary edema. That means fluid actually in the lungs and a history of MI. The physician suspects cardiogenic shock, which is very common after an MI because when you damage the heart, now it weakens the heart muscle. So a lot of times after an MI, the two most common reasons people develop heart failure are myocardial infarction and long-term hypertension. The other reason is stimulant addiction. So like addiction to cocaine or meth, those are stimulants or uppers. So they cause people use cocaine, methamphetamines. It causes them to have kind of a chronically high heart rate and blood pressure. And so that can also cause heart failure. Which initial diagnostic test is most helpful in confirming this diagnosis? So it's really how do you diagnose cardiogenic shock? Well, how do you diagnose decreased cardiac output and changes to the heart? Echocardiogram, 12-lead ECG, chest X-ray, serum electrolytes. So we know C and D are not correct. Can you diagnose cardiogenic shock with a 12-lead ECG? 12-lead ECG just shows electrical pathways. Now, there often are changes to the ECG with cardiogenic shock, but that's not a diagnostic. It's just sort of a comorbidity. Whereas an echocardiogram, you can actually visualize the blood moving through the heart. You can visualize the heart muscle. You can measure cardiac output. So echocardiogram is the gold standard for diagnosing heart failure and any problems with the heart muscle. A nurse is caring for a client with cardiogenic shock who's receiving IV dobutamine. Which assessment finding indicates that the medication is effective? Improved peripheral pulses and warm extremities, heart rate of 120, mean arterial pressure 55, or urine output of 0.3 ml per kilogram per hour. So I know dobutamine is an inotropic agent. Okay, there's dopamine and there's dobutamine. How are you going to remember the difference? I'll be honest, I have a very hard time remembering the difference between dobutamine and dopamine. But dobutamine is an inotropic agent. That's primarily what it does. It strengthens the force of contraction. It's standard of care in cardiogenic shock. Dopamine has a number of different actions depending on the dose. So dopamine is very dose dependent. So I don't know if it helps you to just remember dopamine is dose dependent. Dobutamine is used for cardiogenic shock. That doesn't really help me, but if you can memorize it, that's fine. So dobutamine is an inotropic agent. So it doesn't increase heart rate. In fact, that's one of the reasons we like it. So it does not increase heart rate. Mean arterial pressure here is too low to be considered effective. So we would want mean arterial pressure to be above 65 or higher. So a 55 MAP is actually not effective. And urine output, you can measure urine output two ways. Either 30 mils an hour is one way to determine adequate urine output, or 0.5 to 1 mil per kilogram per hour. So half to 1 mil per kilogram per hour. So 0.3 mils per kilogram per hour is too low. So that's inadequate. C is inadequate. B, we don't want the heart rate to go up. So we go, well, B, C, and D are all wrong. So is improved peripheral pulses and warm extremities an option? Well, if they're going into cardiogenic shock, we would expect them to have decreased urine output. We'd have weak, thready pulses. We could have cooler skin. They could become pale. So the fact that we increase cardiac output, we've been an inotropic agent, dobutamine, seems like it would make sense that we would have improved peripheral pulses and warm extremities. This is an example of the right answer is the right answer because of the other answers. So this is true. A is true. It's not the best indicator that it's effective. For me, the best indicator would be urine output. If urine output was low, I would want it to go up to normal. If MAP was low, I'd want that to go up to 65 or higher. Those would be the two best indicators for me that it's effective, but those options are not there. So again, remember, the right answer is the right answer because of the other answers, and B, C, and D are all completely wrong. A nurse is preparing to administer carvedilol to a client in mild cardiogenic shock. Which assessment finding would cause the nurse to hold the medication and notify the provider? Okay, that's a weird word, mild cardiogenic shock. I would think that it would be heart failure maybe, or early cardiogenic shock, like you're starting to see the heart rate go up. Like, that's a strange word. Nevertheless, which assessment finding would cause the nurse to hold the medication, notify the provider? So it seems like, although it has the word cardiogenic shock, it seems like the key thing is this is really a med question. So blood pressure of 144 over 82. Well, carvedilol is a beta blocker. Remember, alols are beta blockers. It's actually the only beta blocker approved for use with heart failure, or the only one that I ever see used for heart failure, because beta blockers slow heart rate, which is fine, but they also decrease force of contraction, which is not fine with heart failure. So carvedilol has a mechanism of action that does not decrease the force of contraction as much. So it can be used with heart failure. All right. Anyway, but it's still a beta blocker. Okay. So the blood pressure is fine. That doesn't make me hold a beta blocker. Heart rate of 55. Well, 55 is low. So I might say, maybe that would slow it down. I might need to notify the healthcare provider to see if they still want me to give it. Respiratory rate of 20. It shouldn't have any effect on the respiratory rate. Oxygen saturation of 92 on room air. Well, that O2 sat is too low, but it's not going to be affected by the carvedilol. It's not going to have any effect on that. So the question doesn't say which would cause the nurse to notify the healthcare provider. It says which one would cause the nurse to hold the medication and cause the healthcare provider. So the only one that's out of normal that would be affected by the carvedilol is B. The nurse recognizes that one of the earliest signs of cardiogenic shock is decreased urine output, profound hypotension, significant alteration in level of consciousness, or tachycardia. So profound hypotension is later. Significant alteration in level of consciousness is later. If it said restlessness, this would be a really tough question to answer, because restlessness and mild anxiety is an early sign that someone is going into shock, but that's not here. It's a significant alteration in level of consciousness. So for me, it would be between A and D, and I would have to say which one would come first, because it says earliest. And so the earliest is always tachycardia. The body picks up the sensors, and the body picks up the blood pressure starting to go down. And so it increases heart rate to try to compensate for that. A client is diagnosed with cardiogenic shock after a large anterior wall MI. Which of the following hemodynamic findings would the nurse expect? Decreased pulmonary capillary wedge pressure, increased central venous pressure, decreased systemic vascular resistance, or decreased heart rate? Well, I know I can cross off D, because if we're going into shock, cardiogenic shock, we're not going to have a decreased heart rate. Okay. So the other questions. So you might say, well, do I have to know pulmonary capillary wedge pressure? No, but let's see if you can figure out what these words mean without necessarily knowing exactly what wedge pressure is. Pulmonary capillary. Where is the pulmonary capillary? Well, the pulmonary capillaries are in the lungs, right? It's in the lung. Maybe just in the artery exiting the right ventricle. So close to there, pulmonary artery. So, or capillaries. So if think about the pressure, don't worry about the wedge and all that kind of stuff. Okay. Think about the pressure. If blood is backing up from the left ventricle and it gets into the lungs, and there's more volume in the capillaries, the arteries, and the veins of the lungs, would the pressure go up or down with more volume in those pulmonary arteries and veins? Well, the pressure would actually go up. So it doesn't make sense that you'd have a decreased pressure. Okay. That doesn't make sense. Increased central venous pressure. So the venous side, would you expect the venous side, remember it's all on the left, it's all arterial, and then you have the venous side on the right that's coming back to the heart. I mean, you have veins on the left side of your body, but you know what I'm saying. Okay. So you think about it's leaving the left side of the heart, it's going back to the right side of the heart. So it's leaving the arteries and going into the veins. So you have decreased cardiac output. So your arterial side is not necessarily increasing pressure, but it's backing up. Wouldn't it back up into the venous side? So if central venous pressure, would it increase the central venous pressure? Well, actually, by the time they start going into shock, it actually would. So at first you'd see jugular venous distension, and you'd see an enlarged liver because it's holding all that blood. But eventually you are gonna see an increased central venous pressure because you've got the backup of the blood into the venous side. Decreased systemic vascular resistance. Okay, systemic vascular resistance is really arterial. So with the resistance, which has to do with dilation and constriction. So if it's decreased vascular resistance, you have vasodilation. Would I expect vasodilation and shock? No, I wouldn't expect that. That doesn't make a lot of sense. So actually, if we're just looking at the words and we don't even try to, we're not talking about how to measure any of this stuff or any of this. We're just thinking conceptually, the pressure on the venous side actually goes up. Okay, so that's where it goes. That's how you figure out the right answer here. A nurse is assessing a client with cardiogenic shock, which are the following clinical manifestations would the nurse expect to find? Okay, shock, cardiogenic shock. So fluid volume overload, decreased cardiac output. Crackles in the lungs. Yes, because it's backing up into the lungs. Bounding peripheral pulses. No. Oliguria. That's decreased urine output. Yes, you would expect that. It doesn't say late or early or any of that stuff. So we're just generally looking for signs and symptoms of cardiogenic shock. So crackles in the lungs, yes. Oliguria, yes. Jugular venous distension, yes. Bradycardia, no. Hypotension, yes. So I hope you understand, based on all the things we've talked about so far, hope you understand why all those are the correct answers. A nurse is preparing to administer medications to a client in cardiogenic shock. Which medications might be used to improve cardiac output? So we improve cardiac output by giving an inotropic agent. So the question is, are any of these drugs inotropic agents, which increase force of contraction? Dobutamine, yes. Remember, we talked about that. Dobutamine is an inotropic agent. Metoprolol, that's a beta blocker. Alol, actually decreases force of contraction. Milrinone. Milrinone is an inotropic agent. You're just gonna have to memorize it. I don't know any other way for you to learn it, but it's another IV inotropic agent you can give. Digitalis can be given IV push or PO, but digoxin is an inotropic agent. Furosemide is a diuretic. It doesn't strengthen force of contraction. Lisinopril is an ACE inhibitor. It lowers blood pressure, but it is not an inotropic agent. So the only three here that increase force of contraction are A, C, and D. A nurse is planning care for a client with cardiogenic shock who's at high risk for complications. Which of the following complications are most directly associated with cardiogenic shock? All right, so cardiogenic shock complications, I would think that would be related to fluid backing up in the lungs and causing a lot of problems with fluid in the lungs, or poor perfusion of the tissues. That's just what makes sense to me. So let's see the answers. Acute renal failure, COPD, pulmonary edema, liver cirrhosis, arrhythmias, or disseminated intravascular coagulation. Okay, so let's kind of do the standard SATA question. So acute renal failure would be a complication of cardiogenic shock. Yes, because it's poor perfusion of the kidneys. Remember, 25% of cardiac output goes to the kidneys. So it would be COPD. COPD is a chronic disorder, has nothing to do with cardiogenic shock. Pulmonary edema would be a complication of cardiogenic shock. Yes, remember I said fluid in the lungs, which is pulmonary edema. That's what it is. So yes, liver cirrhosis. Cirrhosis of the liver is also a chronic disease, so you don't really see chronic conditions really coming from an acute complication of cardiogenic shock. Arrhythmias. Actually, yes, because when you have decreased cardiac output, that includes perfusing the tissues of the heart. And so when you impaired tissue perfusion, you're not perfusing the tissues of the heart, and that can cause arrhythmia. So actually, yes, it's a very common complication of heart failure. Disseminated intravascular coagulation, or DIC. So you may not know this, but DIC comes from an inflammation, kind of system-wide inflammation that's associated with poor perfusion, and it causes coagulopathy. whether you know the patho or not, that's fine that you don't, but it causes coagulopathy. Eventually, it actually leads to bleeding. So it's this weird thing where at first they clot and then they bleed out. So that is actually a complication, honestly, of all shocks. DIC is a complication of all shocks. A nurse is caring for a client with cardiogenic shock who's hemodynamically unstable. Which immediate interventions might the care team implement to stabilize this client's condition? So it says might they implement. So that means really I'm looking for anything that could be used. It's not first line or anything like that. It's just things that could be used for cardiogenic shock. So insertion of an intra-aortic balloon pump is used to stabilize patients with cardiogenic shock. That's actually true. If you don't know that, you can memorize it. Intra-aortic balloon pump decreases afterload. So afterload is the pressure against which the heart has to pump, and the higher the afterload, the harder the heart has to work. So when you have a weak heart or a failing heart, you want to decrease afterload in an intra-aortic balloon pump. And it's just like it sounds. It's a balloon in the aorta. They actually inflate it during diastole and they deflate it during systole, and it helps pull the blood out of the heart. So it decreases the work of the heart. Administration of packed red blood cells helps stabilize a client who's hemodynamically unstable in cardiogenic shock. Well, they're fluid volume overloaded. So giving more fluids is not really the answer. So that's not true. Administration of IV fluids at a rapid rate, again, would help stabilize a patient in cardiogenic shock who's hemodynamically unstable. That's not true. We don't want to give fluids, already fluid volume overloaded. Continuous infusion of inotropes would help stabilize a hemodynamically unstable patient in cardiogenic shock. Yes, inotropic agents we use. Vasopressors could be used to stabilize a hemodynamically unstable patient in cardiogenic shock. I told you we have to use them sparingly. We have to be careful about them, but they can be used, right? So first we diurese them, then we do inotropic agents, and then we can, if we have to, we can do vasopressors. Okay. Well, I hope that was helpful. And I hope you have a great rest of your week. Keep sending me tips on what you want me to teach about. I have gotten a couple things that I'm going to do. I'm going to try to do more shocks for you guys. I've had a couple people ask me to do more shocks. So send me your requests on what you want me to teach about. If I don't do it, it's probably because I can't do it because it's being taught as part of the clinic review. So I'm not going to do anything here on the free YouTube channel that conflicts with our paid products, right? So we've got to make money. So we have paid products, but we do this YouTube channel sort of to offer you help for people, first of all, can't afford to pay for it. So we can offer you something because we do care that you pass your NCLEX. And also to advertise our paid products, okay? And to show you that we offer quality products. So thank you very much for watching. Thanks for being a part of the Clinic Review family. Take care.